We're going to cover the City and Hackney enhanced services that CEG provide resources for, and we're going to focus on the payment and the KPI indicators. We also want to really show you the CEG resources that are available to support you with the enhanced services. So we're going to show you templates. Which templates should you use? Payment and recall searches, how to navigate these searches. There's a lot of them, so we're going to give you a flavour of what there is out there. And if appropriate, what documents do we have to support it? What aren't we going to cover? We're not going to cover the contract service specifications in depth. Claire and Amaya, their Confed colleagues, have already done this in an earlier webinar, and also you can go to the GP Confederation website for details. I'm starting off by looking at the Mental Health Alliance contract. The aim of this contract, probably as you all know, is to do regular reviews and support for patients with mental health conditions. 5 key elements around depression reviews, SMI physical health checks, patients who are on antipsychotics and not on the SMI register with a physical health check, neuroleptic depot injections, and ADHD reviews. Depression reviews, no change, but just to flag up what's required. Payment indicators are for 16 plus on the active depression register. Active depression means somebody with a cough depression code and who are on antidepressant medication in the last 6 months, and they need to have an annual review done in the financial year. 7 elements. Depression review coded offer of talking therapy last 24 months, social prescribing last 24 months, med review, emotional wellbeing leaflet in the last 24 months. There's a little screenshot there of what the leaflet looks like, and there's a link in your template, so you can just click the link and print it out for patients. Smoking status recording, alcohol status. I'm only mentioning the upper targets, which is 36%. Last year, U practices did very well in the Mental Health Alliance contract. Template. The template to use is the LTC City and Hackney template. To access that template, I'm assuming that most people know, but if you don't, you can get the templates when you're in consultation mode. You run templates, and all our CEG templates will have RP in the title. If you use the F12 protocol launcher, you can use that and you'll have all the up-to-date versions there. Okay, so the LTC template is a smart template, so it only shows up when a person in front of you has the condition. So, for example, what I mean by that is if the person has depression, there'll be a page which will show up saying depression review. That's when you can start entering your data. There is a standalone depression review template if you want to use that. Declined codes, there's a number of decline codes on the template for things like smoking status or declining social prescribing, and they will also form part of the code set for your achievement. SMI physical health check, again, luckily no change in this. Payment indicator, it's for SMI patients not in remission who've had a full physical health check done in the year. Health check, there's 9 elements. They're listed below, and again, hopefully most of you are familiar with them, but they're things like BMI, BP, smoking status, and nutritional and physical activity status. Upper target for this, 80%. Again, that was achieved across City and Hackney last year, so well done. Second payment indicator in this domain is also to do with physical health check care plans. Patient Knows Best, you get £20 if you onboard patients onto Patient Knows Best, and that's really what we're asking practices to do. However, in absence of PKB, you can give patients a paper care plan, which is in your documents, and that's £10. No targets for this, paid on activity. Just one thing to note is that the COF SMI also requires a comprehensive mental health care plan, which you need to document in the record. Coding is different to this, but we've highlighted that on the template, so it should be clear which code you need to use for which plan. Okay, template. Again, you're going to hear LTC template to be used in a lot of our presentation this afternoon. As I said, this is because it's a smart template and contains many of the registers. You can see highlighted the SMI review page that will show up if the patient's not in remission. And again, as part of the contract code set, you can put in decline codes where patients decline things for assessments or blood tests. Third one, on antipsychotic medication. These are for patients on antipsychotic medication who aren't on registers LD, SMI. We're excluding those patients, and they need a full physical health check in the financial year. Health check, 9 elements, same as the SMI. Upper target for this one, 73%. There's a new element, new payment indicator, and that is these patients can also be given physical health check care plans. This is different from last year. So again, patient knows best or paper plans in absence of PKB. If you're listening to me and think, I don't know what she's talking about when she's talking about patient knows best, please contact the GP Confederation because they'll be able to give you some support on this and some training. Template, again, LTC template, and again, you can use decline codes. I've done a little arrow there to see that there's a little box where you can put if patient is declining, and that'll be picked up in our searches. Neuroleptic depot, no change on this. You get paid for patients who've had a depot injection in quarter, and it's £75. LTC, City and Hackney template. ADHD, oh, sorry, I've gone too quickly. Let me move back. ADHD reviews. This has been updated so that it now includes adults as well. So you're getting paid for patients on the ADHD register who are on medication and who've had an annual health check. Remember, you also need to do a meds review for that. It's £27 for one review per patient per year. 2 templates for this. For adults, use the LTC template. And for children, use the LTC children's template. There you can add the review codes as well as doing the review. Mental health searches. We have all our searches in population reporting. You can find them underneath the clinical effectiveness group domain, and you'll find practice support 2024 to 2025. We are trying to streamline our searches. You'll see on the right-hand side that we're trying to make them simpler for you by having 00 for payment indicators, 01 for support and recall. So payment indicators do as they say on the tin, really. They kind of monitor achievement, how you're getting on with achieving the indicators. And then there's a number of support and recall searches. For mental health, you can see that we've got appointment searches. These will identify patients missing activity who've got an appointment booked. Individual searches identify patients with just one indicator missing, for example, those ones. And then we've got the list reports, which are also called PID. And they are reports which will clearly show which elements are missing for each patient. So all those different types of searches are very helpful to help you achieve in this contract. What am I doing for time? Just keep an eye. Okay, just don't forget 2 things just to flag. Remember to refer SMI patients who have poor diet or exercise to core sports. Referral form is in the document. There's a little screenshot of what it looks like. And also just to flag that patients with LTCs, for example, diabetes and COPD, can be referred to talking therapists, and the referral form is in the documents. They don't necessarily have to have anxiety or depression, but you can refer them if they've got an LTC and struggling with management. That's the end of that's the end. Actually, we're going on to the end of life contract, and there's no change in this one. The aim of this contract is to improve the quality of end-of-life care and enable patients to die in their preferred place of death where possible. So the payment indicator, patients on the anticipatory palliative care register with a completed template. What you need to be doing in practice is identify patients who may be in their last year of life and then code with that specific code, anticipatory palliative care. This will also put patients on the QOF register. The completed palliative care template covers new or a review of the urgent care plan, UCP, a resuscitation discussion recorded, preferred place of death recorded, preferred place of care recorded. And this is an activity-based payment, but you do need to achieve minimum caps, and the minimum caps will be coming out to you shortly from the GP Confed. Just to remind you, there is a KPI, and 40% of the contract value is based on achieving 60% of patients dying in their preferred place of death. If we look at the template you need to use is called anticipatory palliative care. And you'll see that I've just highlighted all the little indicators there, urgent care plan, etc. You can also code actual place of death on the template, which, as I said, is important for the KPI. There are a number of decline codes that you can put in, which will also be picked up in the searches for achievement of this contract. End of life searches, they're in the end of life folder, and you've got the payment indicator 00, and then, as I said, 02 support and recall. These include searches so you can identify patients who are missing activity. You can identify patients who are on the QOF register but not added to your APC register. That's an important search if you're not hitting your minimums. And then you can identify patients who have died without place of death recorded. The wound care contract, no change in this contract. What's this one? This is the payment indicator is incidences of wound care performed in primary care for patients who've had secondary care intervention, e.g. A&E inpatient procedures, but excludes minor surgery. And there's different tariffs for if you're doing it at the weekday and at the weekend. Which template? Use the surgical aftercare City and Hackney template, and the first page is called post-operative wound care. You could then code if you're doing post-operative wound management for people who've been generated from secondary care. Code that for each incidence you do, because you get paid on incidences in this contract. Please also code the reason for wound care. Are you doing it for a burn? Are you doing it for a trauma wound? Whatever, just if you can also code that. And of course, if you're removing sutures or clips, you can code that here too. The wound care searches are in our folder post-operative wound care. They're split slightly differently because you get paid quarterly, so they're split quarterly. You can see on the right-hand side that you can look to see the patients that you did on Saturdays and Sundays, the patients that you did on Mondays and Fridays. In the support folder, we've done a couple of searches there for you. You can look at patients who've had removals of sutures, but they've not got the post-op wound care. And if that was being generated in secondary care, it might be that you want to review. So there's a couple of useful little quality searches for you to have a look at in that folder. Phlebotomy, no change. You get paid on incidences again of blood samples or GTT taken in the practice. Which template? The phlebotomy template. And on that, quite a simple template, you've got blood sample taken, glucose tolerance test. Again, searches, phlebotomy to 24 to 25, and it's broken down quarterly. So you'll be able to see the numbers or the incidences that you've been doing. I just want to flag up one thing that's in the, actually, I think it's in the indicators folder, but there are patients who seem to be coded with more than one instant of blood sample taken on the same day. Now, I'm thinking that you might have some patients where that's true, but we seem to be coming up with other patients where the blood sample taken just seems to have been entered twice. So if you could check those for accuracy and see how you're recording this in your practices. Teledermatology, no change in that contract. And this contract is to improve access to specialist routine diagnosis and treatment plans for skin disorders in primary care. The template to use is teledermatology. And there's a number of prompts there that you can record: referral to the service, reports received after referral, clinical photographs taken. The actual payment figures don't come from us. We do produce a dashboard, however, so you can see how you are progressing in this. I think I've actually finished on my bit, but I think what I didn't say was that we were going to take questions at the end. So please write them, where you write your questions, but then we'll look at them at the end. And the other, pop them in the chat box. That's a quicker way of saying it. And I'm going to stop because I'll otherwise take too much time. Thank you. I'm passing over to Shazia.
Thank you. Okay, so just a reminder, we do have a short amount of time today, so I'm not going to go into great depth on these. But if you do have any questions, again, please save them for the end, pop them in the chat box, and let us know at the end. So moving on to proactive care home visiting. The aim of the contract to identify and provide proactive care to patients who are housebound or temporarily housebound to ensure that their health does not deteriorate. So the key elements of this are, there are two sections. There's 90% of the contract payment, and that's been apportioned to achieving your payable register. So you will have individual practice targets that will be coming out to you from the GP Confed. But in order to become payable, a patient must have 2 or more visits in year. And so this should be GP led. So it should be GPs who are doing the home visits. And 1 visit may be undertaken by a pharmacist. They additionally need a holistic needs assessment done in year. They need their care plan to be reviewed on the same day as 1 visit. So I put there to UCP, that's urgent care plan. That's the platform of choice. So that needs to be reviewed on the same day as 1 of the 2 visits in year. And new this year is if any of the patients on the register, as they will likely be, are aged 65 or more, they need to have the Rockwood frailty diagnosis coded. So I will be coming back to that frailty coding because there are some additional notes to be discussed around that. But that's what you will need to achieve for 90% of the contract payment. Then the remaining 10% of the contract payment will be based on your achievement of 3 KPIs. So 2 of these KPIs have not changed, and that is that you either give the patient a flu vaccination or they have declined in year. As you all know, we're not in flu season yet, so we'll be looking at September onwards for that activity. Additionally, they'll need to have had their pneumococcal vaccination, so ever to have had that, or to have declined it in year. Now, the new KPI this year that has replaced that frailty component is a medication review. So your patients will likely be on multiple medications, and so they will need to have a medication review performed in year, either a full structured medication review or to have a medication review performed at visit. So just on to the next slide. So again, just to reiterate what the changes are. Newly this year, remote visits. This is a question I get all the time. Do remote visits count? This year, they have been taken out of the contract. So last year, we would have been looking at your consultation types and saying, right, this was a remote one of these will count. This year, remote visits are no longer counted. So please be mindful of that. Additionally, so we've already spoken about this, but frailty was changed from a KPI into the core payable requirement. And then that KPI was replaced by the medication review. Got 2 mouses, so mice. Thank you. Yeah. All right, so just having a brief look at the searches. There hasn't been a huge change this year, but I've done some relabeling. So as Joe has said, we've got a typical folder structure. 00 will be your payment indicators. So this is what it looks like in the Practice Care Home Visiting suite. At the top now, you'll see that's clearly labelled payable register, a little bit of elaboration on what that means, 2 visits, 1 with a care plan review, holistic needs assessment and frailty. And then you've got your labelled KPIs below. So the KPIs will be based upon your payable register. On to the next slide then. Please work. There we go. So another search overview. So this is a snapshot of the recall folder. So this has been available to you for the last 1 or 2 years. So nothing has really changed in here. But essentially what this recall folder allows you to do is to arrange your recalls by the number of visits that patient has had in year and also what might be outstanding. So right at the top there, you'll see they've had 0 visits in year. They've had no visits. And then it's further broken down into those patients who have never been visited because they may be a new addition to the PCHV register. And then you've got just below that, those patients who were last visited at least 2.5 months ago, to give you, if you're aiming for a quarterly visit, then that will give you a little bit of lead time to arrange the next visit for 3 months. One key thing actually that wasn't on the slide that I should double down on is that for the 90% payment, not only are you achieving your payable register, you need your 4-visit average. So a patient can have 2 visits and they will be payable, but across the entirety of that register, you will need to achieve a 4-visit average. So one patient can have 2, another patient can have 6, 8, 10, however many they have, the average will be 4 across that payable register. Okay, so coming back to this, you've got the 0 visits and then the 1 visit. What I've done here is I've tried to give you the opportunity to capture any outstanding activity at this point. So that's why you'll see under the 1 visits, you've got they need only a visit, they need the holistic needs assessment to give you that opportunity. And then down at the bottom, you've got the 2+ visits in year. Yes, you might have achieved 2 visits. The patient may have become payable, but you still need to continue visiting them quarterly if that's your plan for them. The new thing this year is the list reports that under each of these sections, 0 visits, 1 visit, 2 visits, you've got a list report. What that will do is it will give you the patient details. It will tell you when they were last visited. It will, again, as Joe had in the mental health contract, tell you if they've got any upcoming appointments or planned contacts. And then additionally, this year, we have put in columns to allow you to see, have you achieved the core payable activities? Have you achieved the KPIs? So you'll see this patient has had a same-day care plan review. This patient has had a holistic needs assessment, and so on. So that's a little bit of help for those of you who like to use these reports to plan your activity. So just a quick snapshot of the proactive care template. So you'll actually have I've brought it back to version 1. So just a quick word on our templates this year. Some of our template numbers are getting quite high. So what we've done is, as we've come into 2024-25 and we've updated, we're bringing it back to version 1. So you will have version 1 available to you now in your system. And this is, I've just highlighted the proactive care home visiting register page. And you'll see that this is where you'll be coding your activities. So at the top, you'll be able to adjust your register. We will give you a reminder of the key payable activities, and then you'll be able to go through and code this activity using this template. This is the same template. I've not put another screenshot in later down the line, but this is the same template that you will use for proactive care practice-based. So, as I said, back to frailty, just a couple of points to make on this. So all patients aged 65 plus must be coded for the frailty diagnosis. So that's the key thing to note here, is that we're looking for a diagnosis. We're not looking for a frailty score. So that is one of the key updates that we've made to the templates. If you go to the frailty page now, and I will have a screenshot of that in the next page. But essentially, if you go to that page, you will be able to put the clinical frailty diagnosis, and that's what we're looking out for. So the commissioners also have asked that we ask you to dual code. So you have 2 separate ways of coding your frailty. You've got the Rockwood clinical frailty scale, which is the preferred frailty scale for NEL, but you've also got the generic mild frailty, moderate frailty, severe frailty. So the commissioners have asked that you code this on the same day. However, for the purposes of this contract, for the payable, for the support searches, we are only looking at the Rockwood coding. We have given you a report to allow you to see where this coding might have become desynchronized. And the additional thing that we've done this year as well is we've given you the ability to code the full range. So if you have assessed the patient and they're well, pretty unlikely if they're a housebound patient, but you can add on the full range this year. Now, we've been asked to include the entirety of the frailty scale. So that's from frailty score 1 to 9. An EMIS quirk here is that frailty score 9 is not picked up by QOP. It does not treat that as severely frail. So it's even more important that you are coding severely frail alongside this. Okay, so just to make it a little bit clearer, here is the new frailty page on the template. So you can see, if the mouse complies, that you've now got the ability to select from the drop-down list the Rockwood frailty scale diagnosis. So that will say frailty scale 1, 2, 3, 4. And then just below that, you will see, and my mouse won't highlight, but you can see the next drop-down box will have mild frailty, moderate frailty, severe frailty. And we do have a little reminder of what the conversion is down towards the bottom of the template. And in red, I don't like using red on the templates, but just to remind you that EMIS does not pick up frailty scale 9 as an indicator of severe frailty. So just a reminder to code severe frailty alongside. We said we'd answer questions at the end, but I'll just say, Dr. Gold, you have Proactive Care Home Visiting version 2. That's out today. So if you want to download that and give that a run, that should not be failing. Okay, so that was Proactive Care Home Visiting. Now we're on to Proactive Care Practice-based. So again, key elements are that you are reviewing your patients and they will become payable under 2 tiers. So for tier 1, if a patient needs to have had 2 reviews, and one of the reviews must be done by a GP. So for tier 1 and tier 2, half of the work needs to be done by a GP. The other review can be done by a healthcare professional. So for tier 1, 2 reviews, one by a GP. One of the reviews will have a same-day care plan review. Holistic needs assessment also needs to be done in year. So very similar to proactive care home visiting. None of that has changed. However, as we've seen with proactive care home visiting, if your patient is 65 or over, you will need to be coding your Rockwood frailty diagnosis. Then for tier 2, it will be paid at twice the payment of tier 1, and it's twice the activity. So you have 4 reviews and 2 will be done by a GP. You will, with tier 2 specifically, it may be seen that actually it's more appropriate to visit the patient at home, one of the reviews. So if you do a home visit, if a GP does a home visit, it will count as 2 reviews. Again, one of your reviews needs to have a same-day care plan review. You need to have the holistic needs assessment in year, and if the patient is 65 or over, they will need that Rockwood frailty diagnosis. So just a quick look at the searches. So previously, it wasn't completely clearly labelled which patients were payable under tier 1 and which patients were payable under tier 2. So in our indicators folder, you will see those who are tier 1 payable and those who are tier 2 payable. Just a reminder, we do pick up the activity that you have done on patients who have left and died, so not to worry about that. Then my arrow has moved, but this is actually the recall folder. And again, we just try to help you plan your recall in terms of how many reviews the patients have had. So if a patient has had 0 reviews, that is obviously your priority, and you may likely be there at this point in the year. Then if they've had 1 review, again, we try to give you the further opportunity to capture any outstanding key payable elements. So if they've had 1 review, we even tell you if it's been done by a GP or if it's not been done by a GP, so you know, right, I'm getting them in for this clinician and they also need to complete X, Y, and Z. So that's just a snapshot of the support searches. So that was PCPB, and again, I've not shown you the template, but it is the exact same template as the proactive care one. So if you're using our quick launch menu, F12 proactive care, and that will give you the standalone template. Now onto LTC Core. I don't have a lot of time, so this is going to be a brief overview. But essentially, the aim of this contract is that you are looking to identify early and improve for those patients who don't have LTCs, and improve management for patients who do have LTCs to improve the overall health outcomes for patients. Key elements within will be your annual patient reviews. So, for example, you will have your annual diabetes review, annual at-risk of diabetes review, annual at-risk of CVD review. You're also looking to improve control of LTCs. So if your patients are hypertensive, you are looking to make sure that their blood pressure is within the target range. Improve prescribing for key groups. So if patients have, if they are at risk of CVD, for example, you'll be looking to prescribe a statin for them. And again, the earlier identification of LTC. So if you're doing an at-risk review, if you're doing a pulse rhythm check, you are looking to pick up a long-term condition. So the indicators remain the same. There's 27 indicators and there's been no confirmed changes in those. And you do have your additional health inequality indicators. These have not yet been fully decided, which is why I've got a TBC on there, but that should be happening hopefully very soon. So just a brief look at the searches. These are your indicators in our 00 folder. These are your reporting reporting searches. As Joe said, this is how you'll monitor your achievements. It's all the same. However, you might have noticed that we've done something slightly different this year. I don't know if you're the same as me, but you're looking at 27 indicators, and one up there relates to diabetes, one much further down there relates to diabetes. So what we've tried to do this year is we've tried to group them. So you'll see, even though it's going from C04, G02, all of the indicators with diabetes will now sit together as much as we could possibly make it happen. So hopefully that's helpful for you. I will look for feedback on that. If it's not helpful, maybe it wasn't the right step, but do let me know. So again, a reminder that this year, the same as last year, we do now have a recall folder, and these searches within this folder are the inverse of your achievement searches. So they'll all come from the same denominator, but if you've done a pulse rhythm check on somebody who is 65 plus and you've achieved it, they will be in your indicators. If they're 65 and you have not done their pulse rhythm check, they will be in your recall. So this will help you to stratify your recall. In addition to the recall searches, we do have specific support folders available. So I've just highlighted the CKD one because this one was very, very useful last year. But essentially, if there's an indicator and it's not immediately apparent on how to achieve this, or there are various steps to the process, we will likely have a support folder in there. So for example, in this one, if a patient has evidence of CKD and they've got diabetes, but we've not coded CKD, we'll be looking first and foremost at the coding. Have they used the generic? Is it CKD stage 3, CKD stage 4, or is it that it truly hasn't been coded? So what we've given you here is an easier way to achieve this indicator. And then just a reminder of where the health inequality searches will sit. They will have their own separate folder at the bottom in folder 7. And we do have an idea of what these health inequalities indicators will be. So hopefully those searches will be coming out in the next update. So just a reminder, this is honestly, we're going to repeat this until we're sick of hearing it, but you're looking at the LTC template. So we're currently on version 1.1. And I've just highlighted where you will typically find the page. As Joe has said, this is a smart template. So for the patient that I had here, they have been diagnosed with ADHD, cardiovascular disease, cancer. So you will only see the relevant tabs here. So for any of those patients within the LTC contract, you will be looking to code your activity on this template. And I've just highlighted above as well the PCAs, the exceptions. We will likely often have PCAs within our indicators as well. So if you are struggling with some activity and you're thinking, how do I code this? Again, you've got this tab on the LTC template. So that's LTC core. Now moving on to a newly announced element this year, which is early onset type 2 diabetes, also known as T2 Day. And the aim of this contract is that you're trying to improve the care of patients with early onset type 2 diabetes, i.e. those who are diagnosed and have diabetes at the ages of 18 to 39. So key elements, recommended activities. This is an additional review. Essentially, you've done your care processes, you've done your normal review, and now you're coming to bring them back in to do an enhanced review of them. So this is an additional 30-minute review, and recommended activities within will be looking and making sure, actually, did I complete all of my care processes, or have they got an outstanding foot check? Considering, again, the potential misclassification of diabetes type. So because this is early onset type 2 diabetes, this gives you a further chance to think, actually, is it now showing any signs of potentially being a different classification of diabetes? For all patients, all women who have the potential to become pregnant, you'll be offering them preconception advice. Now, there is a slight overlap between this contract and the early years preconception advice element. So I will just say that there are some complexities around ensuring that all activities picked up correctly and paid for. However, all of this will be dealt with via our searches, and we'll be giving you further information on this, not to worry about that. And just to run through this quickly, you'll be looking to obviously optimize their glycemic control, their HbA1c. You'll be looking at individualized targets, managing hypertension, offering smoking cessation, weight management, and assessing and supporting unmet psychological needs. And the payment for this will be per patient with a review up to a maximum practice cap. And again, that will come out to you by the comped. So I've said don't panic because I've just listed a whole lot of work to be done there. If you are a contract manager, you'll be thinking, how do I make sure that I've ticked all of the boxes? How do I make sure that this is correct? Again, we're back to the LTC template. And what we've done, you may have noticed that you've now got these additional sections within the diabetes review tab. So there's a visibility rule on this. If you pick up a patient who is 50, you won't see this. But for those aged 18 to 39, you will see this in the tab. And that is the box that you tick, extended appointment follow-up, and that is declaring your payment activity. So now moving on from early onset type 2 diabetes to cancer. So key elements within the cancer contract, you've got, and this is not new, the fast track referral safety netting. So you're ensuring that for all of the patients you've referred with suspected cancer, that you know what's happened. Have they been seen? Did they DNA? Have we followed up on that DNA? Then you've got your time to talk cancer extended consultations. Again, these are patient-focused consultations, and you will essentially be calling the patient in, doing a holistic needs assessment with them, and you won't be doing behavioural activity reviews. You are purely there to talk to your patient and try and discover if there are any additional unmet needs, anything they're struggling with that may not come to light within your typical review. You've got the prostate cancer monitoring. So you are essentially monitoring those patients who have been deemed stable under the Homerton Secondary Care Service. And what Homerton will be doing is writing to practices, as they have been doing for the last few years, and saying, right, I think this patient is suitable for monitoring in primary care, and you will make sure that you are monitoring their PSA annually. Additionally to that, if the patient is newly discharged to you in year, you will be offering them a welcome appointment so that they know exactly what to expect from the practice and having monitoring undertaken at the practice. You only need to offer the appointment, but you do not need to, for payment's sake, to have actually conducted it, just to make the offer. And for every patient on here, whether they're new or not, when you get them in, you want to be doing a holistic needs assessment on them as well. And then I've left it to the end, but this is a slightly new element this year. It's called targeted bowel cancer screening. So you'll know that over the last few years, we typically had bowel cancer screening support searches within our searches. And the idea was that you were reaching out to those who might become newly eligible for the bowel cancer screening program, or those who may have been non-responders. This year, with targeted bowel cancer screening, we've got a very specific demographic, which is those who turned 56 or 60 in 2022-23 and who did not respond. And this is not a practice-focused contract. The contract here is that you've had two groups specifically commissioned to come and work with your practice population. So you may be familiar with Community African Network, I had to get that right, and they work with the Black population, the South Asian population, and there's an additionally commissioned group called Ahienu, may have pronounced that incorrectly, who will be working with the Jewish population. So we have created this suite of searches to support them with increasing uptake in these specific communities. For this element of the contract, I will just direct you to the GP Confederation. If you haven't yet signed up and you're interested in having these groups working with your population, please get in contact. Please declare your interest to the GP Confederation so that you can be put in contact with the organisation. So there's not a lot new here, but just a reminder that we've got the fast track referral safety net searches sitting within the cancer suite. On the left there, you'll see what the actual suite looks like. At the top, you will see the payment indicators, and at the bottom there, you've got a snapshot of our support searches. They should all be very, very straightforward. So in the payment indicators, all of the fast track referrals made, everybody who was seen, everybody who was DNA'd, and did you follow up on that? And then in the support searches, if they're currently registered, have they been seen? If not, right, you need to go and have a look at their record, make sure you know what the outcome was. And also if they haven't actually, if they haven't been seen, if they haven't had the DNA, this is where you'll be able to identify them. Time to talk cancer again, very, very small suite here, but that sits within the main cancer suite again, and you've got all of the payment indicators on the side here. So it's actually the middle one, that is the payment indicator. And so it's everybody on the cancer register if they've had an extended consultation. And then the targeted bowel cancer screening. So again, this is just a snapshot. You will see you've got cancer version 2 out in your e-list now for you to copy over. And we've removed the main bowel cancer screening searches from the top there, and we've replaced them with the targeted bowel cancer screening searches below. The payable, it's not payable actually, this is just reporting on the activity undertaken by the community focus groups. You'll see at the top right there the activity. So we're looking at their telephone activity. We're looking at whether they managed to make successful contact, or whether they were unsuccessful, whether a patient was deemed unreachable, which is that they have tried to make a call to them on 3 separate days, whether they went on to complete the actual bowel cancer screening test kit following the successful contact, and just a quick monitoring of how many replacement kits have been ordered. And additionally, below are the recall searches for the volunteers to come in and use. But we will be doing a training for the volunteers, so that when they come to you in the practice, they should already know how to use these. And these are very, very straightforward. I've shown you the Asian population recall folder here, but if they've had 0 contacts, 1 contact, 2 contacts, it's all there, easy to run weekly and for them to get on with. And lastly, the prostate cancer searches. So these sit within a separate folder, prostate cancer folder. At the top there, you'll see the reportables, the indicators. So this will be your register of those who have been discharged from secondary care and monitored in primary care. That needs to be coded by the prostate cancer template, which sits within the main cancer safety netting template. Additionally, we will be looking at, did you manage to do their PSA in year? This is payment upon activity. So if you did the PSA, you will get paid. If you try to reach out to them 3 times, if they've had 3 invitations, so again, 1 invitation spaced at least a day apart, again, that's payable. And then on the bottom right there, we've got some searches to help support and identify who needs to come in. So you can see the patients who haven't had their test done, they haven't had 3 invites, and that little line report will tell you when their PSA should be due. And that's it from me. So it's over to Lewis now.
Right. Name is Luis Rivas. What was I say?
You're going to do the same.
And then they're sitting there so long. Right, so I'm going to go through several contracts, starting off with LTC Children's. This service requires an asthma care plan reviewed annually. What's changed in there is just the target from, I think it was 85 to 87 now. There's also asthma viral-induced wheeze, asthma and viral-induced wheeze A&E attendance. You basically need to follow up those patients within 3 days. Target 35, and then there's also care contact required for patients with diabetes, epilepsy, and sickle cell. So these are sort of GP appointments, medication reviews, care plans, and hospital attendance, that sort of contact. So looking at the, what I'd like to do on this one is look at the A&E attendance, because that's caused quite a few problems over the last few years. It's remained very much unrecorded, and sometimes the activity has been missed. It should be done within 3 days. So I'm just going to go through the process quickly. Let me see if my mouse works. So right at the top here, you can see that there's several pages shown. That's from the template. If you look at the 4th page along, it's called Admin Asthma or Viral-Induced Wheeze. Now that will show you the top part of the screenshot that I've got on the main screen. And so basically, your administrators, when they're receiving a discharge summary, they should be coding, ticking that box, the discharge summary code. Tick that. The discharge summary will have a date, so you enter that on the dates prompt there. So that could be 3 days ago, could be a week ago. You would hopefully hope that from the discharge summary you can do it on the same day that you receive it. That way, there's less of a gap from you receiving notification and the patient's gone to A&E to when you actually kick off the 3 days that you have to follow the patient up. So you indicate whether that's an asthma viral-induced wheeze there, and then down here you code follow-up within 3 days. What you would do then is either send an email or send some sort of notice to the patient's clinician that patient's attended the A&E due to their condition. And then that clinician can then call the patient and do a follow-up and do all the different activities that they need to do. So that kicks off that 3 days that you have. And then if you go to right at the top up here, then there are 2 separate pages. one for asthma review and one for viral wheeze. And then what those show is the bottom side of the screen that I'm showing you down here, which is the follow-up respiratory review. So the clinician, once they click on the follow-up respiratory assessment, and they can indicate whether there's a face-to-face consultation or telephone follow-up, that closes the loop. So you have 3 days. If you don't do it within 3 days, you obviously don't meet the terms of that contract. However, you would still need to make sure that the clinician contacts the patient. So the support services available for this, they're mostly based on the A&E attendance. So starting off right at the top, you've got 2 searches that say missing review, one's for viral wheeze and the other one's for asthmatic children. You've indicated that that patient went to A&E, so they've had the 3-day code, follow-up code added. So those patients will appear on those searches. Obviously, if you miss the target, they'll carry on being in those searches until you do the activity and record follow-up. And then the last 2 searches there are discharged without follow-up. You may find some patients in there that do belong to this register. You know, they've gone to A&E due to the viral-induced wheeze or asthma, but it could be that they went to A&E for something else, like a broken arm. So be careful with that. You shouldn't code follow-up on those just because they're on that list. And then in the center there, we got all the different recall searches for patients that require some sort of annual care contact for diabetes, epilepsy, and sickle cell. Now, moving on to Time to Talk. Time to Talk, this is for patients with 2 or more LTCs who are carers or have long COVID or have hemoglobinopathies, so that's thalassemia and sickle cell. Or if you've added, as a practice, you've added the multiple LTC code. Now, the multiple LTC code is used when in practice, a clinician deems that a patient would benefit from an extended consultation. So they might only have 1 LTC, but they might have other factors that the clinician thinks that they would benefit from this. So you can add that code to put them in this register. So these consultations, the extended consultation of 30 minutes, they're really meant to for the clinician to discuss the patient needs, this sort of a holistic sort of thing. You wouldn't be doing things like assessments, examinations, and blood tests. So this is general discussion with the patient about their care. Now, the contract has a minimum and maximum target. I've highlighted minimum because it's quite crucial in this contract, because every single practice must meet its minimum target. Otherwise, every practice that fails that target, a minimum target, reduces the overall budget by 3%. So the rates that affects the rates of that you get paid for each one of these consultations. So by all means, make sure that your practice meets that minimum target at the very least. Minimum target is very achievable. Maximum target is a huge difference between the minimum and the maximum. The maximum you can, there's lots of practices that meet it, but it's quite a lot of patients with extended consultations. And the more you do, the more you get paid. Now, there's a simple recall search, sets of recall searches for this, just a simple search recall. Within that, we've tried to give you a sort of set of patients that you might consider as priority. So any patients with 3 or more LTCs, so you could action those to start off with. But the main one is first search that will identify all the patients. Now, moving on to early years, targeted preconception. So this is women with a qualifying LTCs. You'll find the list on the searches. Age 20 to 45 years old. Now, this includes hemoglobinopathies. I do know that we started using those late last year, so not exactly new. But the miscarriage in the last 6 months is definitely new. And the register has had the asthma patients and rheumatological conditions removed. So it's a slightly increase and then reduce with others. And then, as Shazia was mentioning earlier, the account does have some crossover with the early onset type 2 diabetes. She said it is quite complicated to get these researches right so that you know which ones you get paid for. So we will be sending out a fact file on this and then discussing this on a future CEG's Tuesdays. I'm not going to go into it just now because we'll go mad with that. So targeted preconception, basically the main elements is that once you contact the patient, they need to express that they're planning to start a family and you code that on their record. And that starts off, they effectively in this register, they coded planning to start a family in this year. And then you do the targeted preconception advice, but that needs to be validated with a BMI done either 28 days before the exam or on the exam date, and that pays £40 as indicated there. Now, in terms of searches, very simple set of searches again. Recall search, not invited then to the preconception appointment. There is a search in there for miscarriage in the last 6 months. Now, it is thought that it is better to call those patients rather than send them a leaflet or anything like that. The service is looking into providing a leaflet that you can send, but for these patients, you would definitely need to try and call them or consider calling them if you are going to invite them. Now, pregnancy presentation, again, that's pays £40 and it requires validations. The elements of the validation are BMI 28 days before or after, or before or on the day of the exam, social and obstetric risk done up to 5 on the day of the exam, so up to 5 days after, an antenatal referral form for 14 days after the exam. Again, support search is quite simple. If you had a first contact done, whether you're missing activity. So if you're missing activity, you can find the list of patients on our first search. But we provided a very nice line report there that will list each patient for you and it will show you each columns of activity. And then you just see the gaps there and deal with that spreadsheet actually. Now, the other component to the maternity is early years, 6-month health and well-being check. That came in a while ago, a few years ago. The eligibility for this are women aged 16 years to 50 years with a vulnerability. Now, the list of vulnerabilities has increased quite a bit from when we first started. I'm just showing, I mean, you can probably barely see it, but I'm just showing a snapshot of it. There's a lot more in there, but you got things like hypertension, disability, stillbirth, homelessness, etc. Again, if you want to see the list, go to the searches, vulnerabilities folder. You can easily see that there. So key elements, 6-month health and well-being check, you get paid £40 for the exam. It is with validation, so BMI from 28 days before or after exam, BP from 28 days before or on the day of the exam, and then you got contraception counselling, preconception advice, and depression screening, all done. They have to be done on the same day of the exam. In terms of searches, I've highlighted the main recall search in there. Within that, the sub-searches that you could use. The first one just shows patients that have delivered naturally. Now, this service does look at patient delivered with the exam done up from 5 months onwards. I know it says 6-month health and well-being check, but from delivery, we're looking at from 5 months onwards up to 7.5 months after that, although we can pick up data later than that. And then there are some complications with this because you're going to have some women who have had the child removed after birth or who have had a stillbirth. And so you need to be careful how you contact those women. There were a couple of different letters for each of these, but the the service is currently working on a single letter that covers all of it in one go. So I'm just waiting for them to publish it. And then this, the other thing with the service is if you look at the search there that says within one invite, this one more invites. That's because if you've invited these women at least 2 times, you don't have to continue inviting them after that. Once you invite them a second time and record that, they'll fall out of the recall search. We'll still pick them up if obviously you do the activity for payment. And then again, you have an incomplete validation search with a nice little line report there. Again, that can be exported onto Excel, and you can look at the gaps in activity. Now, one thing to say about the previous service, the first contact and this service and the health and well-being exam, is that some of the components have to be done on the day of the exam. If you miss them, it's too late. Unless there's something recorded in the consultation that says that activity was done, then it'll be too late by then. Now, the last search there is effectively a data quality search. You basically, if you got any patients there, it means that you've done a 6-month exam and no vulnerabilities have been recorded. So there must have been reason that you did that. So it could be that the vulnerability has remained unrecorded. So you need to check the patient record and record that as appropriate. Now, other components of this early years is the Universal Partnership Plus patients on that register. They'll be children aged not to 4 years old. They require a joint action plan to be agreed with health visitor, and that joint action plan, once if it's the first one, then it gets reviewed yearly afterwards. And so for new action plans, you get paid more, £64, and for annual review, £30 for that. In terms of the searches, the first search shown there is they've had the action plan already before the start of the year, and they require a review. And then the second one is where they do not, they're newly entered into the register, they do not have a joint action plan to discuss, agreed. So again, recall those patients. And then you have like a data quality sort of search, no action plan, but a review code. So it's, they really should have had a no action plan recorded first. Yeah, you need to review and see what's happened there. It could be that the no action plan was recorded, it's on the notes, so then you need to record that. And the only difference with the last one is that it shows you left undiced patients. Now, for NHS health checks, eligibility 40 to 74, excluding already with cardiovascular disease diagnosis or on statins. Also excluded if they've had a check in the last 5 years. And then I just want to highlight a very essential component for this, which is cures calculation is essential for assessment. And that's because every year we find NHS health checks have been done where the cures calculation has not even been done. So looking at KPI targets, this service has a lot of this. So starting off with NHS health checks delivered of eligible population, 12% per practice. There's a 1% for those NHS health checks done on patients with a cure greater than 20%. Now, there's a big question mark on that because the eligibility could be changing on that, so that might disappear. So watch this space, we'll notify you of any changes on that. There's a 25% for health checks done on the Black African, Caribbean, or South Asian population. And then there's 53% target for the male population and under 50 years population. And then on those ones, is that something to note that if you achieve your targets, let's say 53% for the male population, and then you go on to do what's predominantly health checks on women, because it's based on the eligible population with NHS health checks done, that will reduce your percentage. So you think that you've achieved it, and all of a sudden you look back again and it's like 50%. So you got to be careful with that. And the same phenomenon happens with under 50 years old. You could be doing health checks after that on patients up to 74 years old. Yeah. And then there's another target for patients with a Q risk greater than 10%. They need to be referred to or signposted to lifestyle services. And we look at some decline codes for that as well, for achievement of that target. And the last target there is all patients to be issued with a risk report, to 100% on that. Now, I do present on this to healthcare assistants and nurses. So we do cover this again a couple of times, even 3 times a year. Now, just a quick look at the health check template. Just want to highlight just one single thing. At high risk of CVD. So the template will tell you if you start doing a health check, if the patient is already at a high risk of CVD, they should be doing a at high risk of CVD review. So you would change to that template and not continue with the health check. Now, I've highlighted a few elements that to do with the Q risk calculation. Same here on the same page. I will skip that. Now, when you look at the template, the part to do with Q risk, it's a bit complicated in a way because we still have the Q risk 2 calculation there that IMACE has discontinued in terms of batch adding calculation. It's still available for you to use, so by all means use it. However, we've also provided you with the link there within the second bit there. It's highlighted in blue. That links to the web page to the Q risk calculation. The only problem with that is that obviously once you go to the website, you have to be entering all the different information, relevant information for the patient before you obtain your score. Once you obtain your score, then you record it in that prompt. And then also insert the heart rate if you can from the Q risk 2. Now, the bottom side of this slide shows the Q risk greater than 10. So that's just so that you know that there's a whole section that tells you all about the lifestyle interventions, the different services that are available, like Hackney Stop Smoking Service, Healthy Together, etc. If the patient, so you would be referring the patient or giving them advice. But if the patient is already concordant with all the lifestyle conditions, then you record that at the bottom there, and then we'll pick that up on the searches. Are we doing for time? Yeah. 7 minutes. So support and recall. So just a quick, just to show you the searches, they will tell you which patients are missing the risk report. So have a look in there and make sure that that's within 100%. If not, then you can contact the patient, create a risk report, send it to the patient via email, and then have a discussion with them so that you can fill it in, because it requires all sorts of information of what the goals are, etc. And then on the recall set, there's the main search listed there second. There's a whole series of sub-searches in there, and I would focus on things like on the no-risk patients, because no-risk patients, you don't have a Q risk calculation. You don't know whether they're medium or high. So you would want to try and bring those patients in as soon as you can so you can calculate their Q risk. And then there's also the patients for which you have targets of Black African Caribbean, male, Asian, and 50. And then the last search highlighted there is men, Asian, and 50, so that to kill 2 birds with 1 stone, as they say. So that's quite a useful search. And then within the KPI searches, you can obtain a nice little list of all the searches showing you your targets. And can you see that they'll say HCK02 or something like that, -Y, and that's because they're yearly. And you can't see this normally. You would have to click on the full hierarchy on that page, on the KPI page, to see this, and then you just find it a bit way down on the page. If you need help with that, just contact me. Now, the other thing with NHS Health Check is that you have back in October, they introduced the HIV screening to the normal NHS blood search suite. So they put that on TQuest. Now, what you're meant to do, because effectively in the suites, the blood suite. Patients are supposed to be able to opt out if they want to. So for that, as a practice, you have to have all the different leaflets and posters and the practice available for the patient to inform themselves that that's happening. And if they do happen to say they want to opt out, then you, as the person doing the health check, you need to, when you request the bloods, you need to remove the test from the sequest set. So that's fairly straightforward to do. So that's where you need to yourself remove it so that they don't get the test done. Now, sexual health. Going on to sexual health, we're not going to go through all of this, but it includes LARC fitting and removal, implants fitting and removal, sexual transmitted infections, swabs, and condoms issues. I'm just going to go through some issues to do with LARC. The LARC practice activity, what we're looking for is regular patients with a face-to-face consultation type. So if you entered your activity under GP surgery or some other consultation type, then we won't be picking it up. So make sure that you have the face-to-face consultation type as a choice on your consultation. Now, something else to do with that, similar, sort of kind of related, is that hub practices that send notifications letters back to the referring practice. Once you see that letter, you're going to want to record that on the patient record. Now, we do know that some practices were entering the normal LARC codes, which confuse some of the data. So don't do that. Make sure that those letters, if you're going to add a code to those, then make sure that you add the LARC fitted by other healthcare provider. And then STIs, just a quick note on that. STI diagnosis, if these ones need to be claimed effectively, because STI diagnosis can be done by clinics, hospitals, etc. The results come back to you, so you need to know that it is your practice that did the diagnosis. So you can claim that by adding the enhanced service code, and then this is further validated by adding the discuss partner notification code. So it needs two components: enhanced service code and discuss partner notification. Now, you also have new patients aged 16 to 59 to be offered HIV screening, and that's supposed to be done within 3 months of them being registered. And then you have sexually active 15 to 24-year-old patients to be offered chlamydia screening. Now, there's a whole suite of searches. These are payment searches. You don't, you can have a look through those, but they're just payment searches. You're just going to focus on the support searches. As you can see there, for newly registered patients, it gives you a search that says no screening for HIV. So you find patients in there that you need to call in for a test. And then the bottom two searches are those patients that you're wanting to claim for an STI diagnosis. And so use those two, but they do have to have both components. And with the sexual health, there are several bonus payment searches. You can find them on the searches. I'm not even going to go through these ones, mostly because we haven't received full details of what the targets are on these ones. Okay, but watch this space again. We'll let you know more about those ones. We know more. And last of all, I'm just going to go briefly through the latent TB eligibility. Patients aged 16 to 35, no history of TB or LTBI, not previously screened for LTBI in the UK, with any of the following risk factors. I've isolated one list more, identified as flag 4. Why? Because this list is created by public health and provided to practices by the GP Confederation. So if any patients you need to invite are the flag 4 patients. So let's have a look at all the rest of the eligibility. I mean, most of these patients, you can code these ones up and effectively make them eligible. So the first 3 sets have to do with risk due to travel. So born in a high incidence country, spent more than 6 months in high incidence country, or entered the UK in the last 5 years. And the remainder are social risk, So that's ex-prisoners, patients with high alcohol consumption, drug use, whether it's current or past, and homeless. And remember, this only come into eligibility if they haven't been tested or had, before, had to be before. Now, quick look at what you get paid for that. You get $250 per each invite, and that's capped at 3. However, you can be paid for an additional one if the patient has had an indeterminate result or they did not send an appointment that you put for them. So you can get paid for an extra. By all means, carry on inviting them until you get them in for another test, but you will only get paid for an additional one. So a total of 4. Egret says £25, and the TQuest blood test that you would be using is that T-Spot TB. And then all the blood tests that you do under this service, as long as you code them as blood sample taken, they will be paid under the phlebotomy service, not through this one. Yeah, effectively you're claiming them by adding the blood sample taken code. In terms of support and recall, there's fairly straightforward invites, searches, needs a second invite, needs a third invite, or has not had any invite at all. And then this, I'm almost finished. And then this Egret test without an eligibility code. So basically, you've done a test. You need to work out why you thought the patient was eligible. If they are eligible, then make sure that they code it appropriately. Otherwise, we will not be able to pick them up. And then the last search in their DNA or indeterminate are the ones that you would be inviting for that 4th screen. And then ignore the last recall search there.
Okay, thanks, Lewis, and thanks, Shazia. That was comprehensive. I forgot to say at the beginning that we do actually have a guest speaker to talk about the Data Accreditation and Improvement Incentive Scheme for about 5 minutes. And then after that, we'll just look at questions and conclude. So it's Keith, our CG manager. Come in, Keith.
Hello. So this is a NEL-wide scheme, not necessarily not just a place-based scheme, but it does obviously apply to City and Hackney practices. It's called a Data Accreditation Improvement Incentive Scheme, quite a mouthful, and it's got 2 primary objectives. One is to improve data around 2 areas: consultation types and job roles. So that helps us understand who is doing what. And the other is around what we call the wider determinants of health, otherwise non-medical interventions, addressing issues such as loneliness and or housing problems, income problems. And then the second component of this is to embed this kind of data capture into your routine day-to-day practice. So it's in 3 phases. The first phase is around you need to sign up, you need to do your roles and encounters, and you need to have access to the Apex, which is Edenbridge tool. The evidence to demonstrate that you'll have done this will be that you'll send some screenshots into your CG facilitators. Phase 2 is about recording an agreed set of wider determinants of health, and this is monitored through a CG monthly dashboard. Payment for phase 1 is 10 pence per registered patient. Payment for phase 2 is up to 33 pence per patient in an agreed cohort, and that's on a sliding scale. And as I said, there's the third phase, phase 3, which is about embedding this into routine data capture. And this will be done through an accreditation visit, and it will probably be done by either Lewis or Shazia, who will come into the practice and have conversations with several members of the staff to ensure that everything's in place. And the price of that is 10 pence per registered patient. Next slide. So this is an example of a screenshot of what you'd need to send in as evidence for your consultation types and job roles. Literally just go into it, do the properties on consultation types, take this screenshot and send it off to either Lewis and Shazia. Lewis and Shazia look at it, they'll approve it, and then they will send you an actual invoice that you get to send off for the amount of money that has earned you. So phase 2 is broken into 2 parts. There's 3 indicators: ethnicity, main spoken language, and contact preference. And these are set with a target of up to 95% or above, and you'll get 3 pence per patient based on the registered list size as of, I believe, the 1st of October 2023, I think is what we based it on. The second one, you will ask 4 questions. The 4 questions will actually be, not what's on there, but do you have any money problems that make it hard to make ends meet? Do you have any housing problems? Do you have any difficulties understanding information about your health or treatments you're receiving? And do you feel lonely? And the answers to these questions, once you've answered them, there'll be yes, no questions, and you'll get paid on a sliding scale. The sliding scale will be exponential as well in terms of payment. So 25 to 45% will earn you 6 pence per patient. If you achieve between 46 and 70%, you'll get up to 15 pence per patient. And if you get 71% and above, you'll get 30p per patient. And that's where the 33 pence per patient for those cohorts comes from. So this is a copy of the template. You can see the appropriate responses in there, a double asterisk, so you know you need to record them. There are searches in there that will tell you how you're doing in terms of the two cohorts, so you can see who the patients are. Next slide. Okay, just before we go on to the next slide, I'll just talk a little bit about the support that's available. So of course you've got facilitated practice visits. You've just seen the searches. You've also got an Accurate Flurry that enables the patient questions to be asked remotely. The Accurate Flurry will hopefully boost you up so you can get over the 25% minimum. You've seen the template. There's also a practice reception room video that explains to patients why they may be asked these questions. And this is so that if someone's sitting in your reception and then you come up and start asking them questions about whether they feel lonely or not, they've had some information. In addition to the reception room video, we also got some articles published in local papers like the Hackney Gazette and the Newham Post and things to say that this piece of work was going on and why it was beneficial and why you might get asked those questions when you approach your GP. And that's attracted quite a bit of interest nationally, because I think we're one of the few areas in the country that's doing this type of work. There's also a good practice guide that helps with the roles and encounters, to help explain how they should be mapped. And there's also a practice fact file which will go into some of this detail, in much more detail. And then phase 3. So if you hit 25% in those 4 questions, that will make you eligible for phase 3. And phase 3 will be a visit, and it'll be a visit, as I say, probably by Lewis or Shazia, or it could be Joe or myself, maybe, depending on how demand goes for the visits. They'll meet with several staff from the practice, and they will review to see whether you've got systems, your system requirements are in place, to look to see if you've got your training embedded, whether it's components, some components of this are part of your induction process, just to see whether you're likely to going forward be able to keep this up. I mean, we'd also hope that some of this will move into next year's set of local place-based schemes as well, because it does fulfill larger requirements of both national and local programs to do with both health inequalities, which you're probably all aware of, and also the demand and capacity work, which is growingly critical to the delivery of services in the NHS. So without the kind of standardized data that brings to us, we're not really going to be able to get the best out of the resources available, and potentially also hopefully attract more resources nationally into our area. The interesting thing you think about with phase 3 is, as long as you've got your 25% minimum threshold, you can request your visit. And if you pass your visit, if you demonstrate to Lewis and Shazia that you've done all of the things that are needed, you'll get your payments up front of that before the end of the year. And again, that's 10 pence per registered patient. Phase 2 payments, the ones based on those indicators we've just shown you, will be at the end of the year, so you can still keep working towards that right up until the last minute. But as soon as you get over 25%, you can request the visit from Lewis and Shazia or whoever.
Okay, thanks, Keith. I think my kind of message about the data accreditation scheme is that I think the City and Hackney practices, we've got so many contracts that last year maybe there wasn't such a great take up of this, but not only is the kind of reporting of the wider determinant stuff important, but we also don't want you to lose out on the financial part of this. So we will be pushing it a little bit on our visit. I'm going to very quickly do this and just leave about 4 minutes for questions. It's just we want to push what resources we have. We will be offering you face-to-face practice facilitation visits, and we're going to start them early this year. We realise we've gone through a lot of stuff this afternoon, and we can cover some of this in our practice facilitation visits. We also do the weekly e-bulletin. Hopefully everybody's signed up. If you haven't, contact Lewis or Shazia. The last one has a very important thing about, do you want to join our VIP list? VIP, very exciting. You become a validator in practice for early access to our resources, and actually it helps us to make sure we're getting the searches and everything right for you. Also very important, CEG Tuesday, please come along. It's a drop-in team session, and you can, we're there to answer questions, as are our great Confederation colleagues too. We haven't had time to show you the dashboards, but please look at our dashboards because they will see how you're doing on the contracts and also how other practices are doing. You can sort of see how your peers are doing. I'm going to stop there. We can look at some of the questions that have come up. So
before the questions, can I just say that the CEG Tuesdays was originally going to start next week.
Thank you.
But we've had to move it to the week after because of an all-day event that Queen Mary is insisting that we go to. Yeah, so there were two questions. What about mothers who get pregnant very soon after birth? I'm not sure, to be honest. I don't think we have any way of excluding those. But I'll contact the commissioners and inquire about that. But first, I'll have a look at the search to see what we've got there. Yeah, it's not an issue that we considered, I guess. And then the NHS bloods, Claire is completely right. So HIV screening is only for patients with a cure of 10% or above, and generally you wouldn't only request bloods on patients who have had a cure of 10 anyway. So it's not just for the HIV, it's for the lifestyle interventions as well.
Okay, I can't see any more questions in the chat. Are there any more questions? And just to point out, I'm sorry, our camera sort of gave up on us, so that's why we're not on the camera at the moment, in case you're wondering why we've vanished. Were there any more questions?
Okay. So just to say a big thank you to all the presenters, but huge thank you for all of you who've come along to this webinar about the updates for the 24 to 25 contracts. But as I said, where there is a lot of stuff, we will be doing little fact files, hopefully, so that we can explain a little bit more about some of the more complex searches. But really, we want to get out there. We want to come to the practices. We want to talk to you. We want your feedback. We want to collaborate with you to make things as smart and easy as possible for you and your practices. So thanks, everybody, for attending.
Thank you.
Thank you.